Hello everyone, this is Rastogi Ayush from group LA21922. My topic for presentation is traditional and modern information on esophagotomy, the resection of esophagus, and the operation on the atresia of the esophagus, which is guided by Professor Zadni Priyani. The esophagus is a tubular structure about 25 cm long that is continuous above with the laryngeal part of the pharynx, opposite to the 7 cervical vertebra. It passes through the diaphragm at the level of 10 thoracic vertebra to join the stomach. Three parts of the esophagus are distinguished: cervical part, thoracic part, and abdominal part. Esophagotomy. Esophagotomy is an incision to the lumen of the esophagus. Now, before this, we look at general anatomy of the esophagus. The layers of esophagus walls include mucosa, submucosa, muscularis, and adventitia. The cervical portion of the esophagus inclines to the left of the trachea as it runs caudally and ends at the thoracic inlet. The thoracic portion extends from the thoracic inlet, where it is located to the left of the trachea, crosses the trachea to regain its dorsal position at the tracheal bifurcation, and extends caudally to the esophageal hiatus of the diaphragm. The abdominal portion of the esophagus is short and wedge-shaped, extending from the diaphragmatic hiatus to the stomach. Now, indication for the esophagotomy. Indication for the esophagotomy includes foreign bodies, strictures means abnormal narrowing of the esophagus, esophageal perforation, esophagus rupture, esophageal diverticula, esophageal parasitism, and gastroesophageal interception. General surgical principle of the esophagotomy. Esophageal surgery is associated with a higher prevalence of incisional dehiscence than surgery on other portion of the alimentary tract due to several factors may contribute to high complication rate, including lack of serosa, segmental nature of the blood supply, lack of momentum, constant motion caused by swallowing and respiration, tension at the surgical site during swallowing. Preoperative consideration. Fluid electrolytes and acid-base imbalance should be corrected before induction of anesthesia. Patients should be fasted for 12 to 18 hours before esophageal surgery. Preoperative antibiotics may be given to prevent the infection of periesophageal tissues. Now, approach to the esophagus. Approach to the cranial thoracic esophagus via lateral intercostal thoracotomy at 3 to 4 intercostal space. Approach to the esophagus caudal thoracic esophagus at the heart base via right lateral thoracotomy between 8 to 9th intercostal space. Approach to abdominal esophagus via ventral midline laparotomy. Now, the approach to the cervical esophagus. Position of patient in dorsal recumbency inside the skin of the neck of the midline. Paired sternohyoid muscle along the midline to expose the retract sternohyoid muscles. Retract the trachea to right to expose the adjacent anatomic structure including the esophagus, the thyroid gland, the cranial and caudal thyroid vessels, the recurrent laryngeal nerve, and the carotid sheath. Pass a stomach tube or esophageal stethoscope to facilitate the identification of the esophagus and lesion. Make a stab incision into the lumen of esophagus and extend incision longitudinally as necessary to remove the foreign body or observe the lumen. After completing the definitive procedure, close the incision by opposing sternohyoid muscle using absorbable suture in a simple continuous form. Appose the subcutaneous tissue in a simple continuous pattern with 3 or 4 absorbable suture. Use non-absorbable suture and an appositional suture pattern to appose the skin. Post-operative consideration. The patient should not receive food or water by mouth for at least 24 to 48 hours after the surgery. Fluid should be continued until feeding resumes. Antibiotics should be continued for several days if the esophageal mucosa is severely severely eroded or lacerated. Analgesics may be necessary to control pain. Complications: dysphagia, esophagitis, aspiration pneumonia, wound dehiscence, leakage at the surgical site, ischemic necrosis, strictures formation, abscession. Now, the resection of the esophagus. Esophageal resection is a type of surgery in which a part of esophagus or the entire esophagus is removed. The lymph nodes near the esophagus and the stomach may also be removed during this operation. Indication for the resection of the esophagus: carcinoma of esophagus, high-grade dysplasia in Barrett esophagus, destruction of esophagus by caustic injury, esophageal dysfunction, scleroderma, eclasia, spasm, esophageal perforation, recurrent gastroesophageal reflux. Approaches for the esophageal resection: upper midline laparotomy, right thoracotomy, left thoracoabdominal incision, left neck incision. Procedure: the mediastinum is dissected along the anterior margin of left sternocleidomastoid muscle. Then the cervical part of esophagus is retracted superiorly till the tumor is seen, and then the tumor is removed. Now, the operation on the atresia of the esophagus. Esophagus atresia is a congenital discontinuity of the esophageal lumen. That may be of several types, like atresia with distal fistula, atresia with double fistula, atresia with proximal fistula, and complete atresia. Operation on atresia of the esophagus. Preoperative management: maintain a patient airway, prevent aspiration of stomach content or saliva into the lungs, prone position to prevent the stomach secretion from the refluxing into lungs, intravenous antibiotics to help prevent the development of pneumonia. Procedure: the operation is performed mostly through the right side thoracotomy at the level of fifth intercostal space. Mediastinum is then exposed. The zygous vein is divided by ligature. A catheter is pushed into the upper segment of the esophagus by anesthetic to facilitate the isolation of the segment of the esophagus. The lower segment of the esophagus is transected below the trachea-esophageal fistula, and the lower segment is mobilized. End-to-end anastomosis is made between the two ends of the esophagus with the interrupted silk suture through all layers. A tube is passed through the anastomosis for feeding, and an extrapleural drain is inserted. It may so happen that the end of the esophagus may not be brought together. In this case, upper end should be brought to the surface of left side of the neck above the clavicle, and a gastrostomy is performed for feeding. Another methods for operation of the esophageal atresia are gastric pull-up, colonic transposition, and jejunum transposition. Now, let's watch a video to understand how the colonic transposition works in esophageal atresia. That's all for my presentation. Thank you everyone for your attention.